The other last thing I'll leave you with on those documents is those documents are for you to use however you wish and want. Realize that they are living, they're changing over time in terms of what we do in my practice and what other practices are doing, and they are the input of many different docs and many different practices and styles over time that have shaped what that document looks like now. So I want to put back up here, and this will be the backdrop. Dane, my last slide. This will be the backdrop for the rest of the discussion. And I used an analysis of something like this in the US to start to look at things on my practice side. So I shared with you before, it's good to know that somebody sees patients on a regular basis. They're doing this stuff. First, I don't have a silver spoon. I don't have a family inheritance that gave me my practice. I actually bought a practice that was a piece of cash flow in the US. It was about 1,000 square feet and had carpeting up the walls, posters on the walls as well, jewelry cases that were kind of crammed together to house the glasses that nobody could get at, or frames that nobody could get at. And when we went to remove the posters from the walls to repair and do some building, we found holes. So it was really interesting to have this practice and to start out with this thing. When I started into practice, my practice was kind of moving along a little bit, and I had decided some things I wanted to do. So I've been in clinical practice for about 17 years, 16 years, something like that. I was in the Navy for 3 years first, had every toy that I wanted, had every privilege that I wanted to treat every condition and not just manage them that I wanted. And I walked out into California, where in California law at that point, we didn't even have glaucoma. We got it when I got out. And when we got glaucoma, they stuck a little set of handcuffs on you and said, if you want to treat those glaucoma patients, you have to co-manage 50 of them with them seeing the ophthalmologist and you for a period of 2 years. Even worse than saying, here's a glaucoma patient, would you please approve a drug? And then I'll write that prescription, and then I'm going to see them back if you're busy enough as a practice, right? But you guys had it yanked and given and yanked, and I understand that there's some challenges that are there with that around your glaucoma privileges. But that was our glaucoma privilege. And we had really nothing else in terms of therapeutics at that point. So we were challenged to treat or be ready for this set of conditions. Yet I knew that's where we wanted to go because that's what I had done. So in about 2007, so about 3 years into my single location where I took a 35-year-old chair and had it refurbished, and I had a 40-year-old slit lamp, I think, and what looked like an old B&L Greens phoropter that was sitting in there and stuff to just try and get the practice going. I lost about 30% of my patients in the first 6 months because I was making this commitment to medical, and those patients were used to a quick refraction check and a pair of glasses. And what we have in the US is we have 2 tiers on the government side that cover our medical care. We have Medicare for 65 and up. We have Medicaid for under 18 and under, basically under 18. And those 2 pieces don't play real well together. And what's also unique about those 2 pieces is that where they're spread out, they're increasingly becoming what's called managed care. So that managed care component limits the network size, so you can't get access to those patients. In what I might liken that to is you're really like maybe an orthoptist practices here, where they can't get access to certain patients unless they have a referral from one of you or from the primary care for somebody else. But it's even worse than that, because even if I had a referral and I wasn't in network, I still can't get paid and I'm trying to treat this patient. Everybody on the in-between in the US has what's called a commercial, or somebody, not everybody, but most people have what's called a commercial carrier that covers the middle of that road. And the commercial insurance for years was fee for service, which was great because you'd come into my practice, or you'd come into my practice, and I would say, yeah, you've got this condition, here's what's going on, and you would say, great, I've got a $10 copay, perfect, and then I bill the insurance, and the insurance would pay me the rest. That's gone. Poof. It's really gone. And it really went away when healthcare reform happened in the US. And the reason it went away when healthcare reform happened in the US is the same reason that pensions in our country transferred to 401ks. There was a shift in the financial responsibility from the payer, from the third party, to the patient. And so now, when a patient carries a $5,000 to $8,000 deductible, which most of our patients do, guess who bears the brunt of the cost? So guess who has to make a case to the patient about the care and the quality that we're going to provide. And so regardless of what you might have heard about the US, unless you live in one of those panaceas like Kentucky or Oklahoma, you have a very competitive marketplace with a very competitive payer mix. And when you sit in the middle of Roseville, where 3 miles around me, I have 11 or 12 independent practicing ODs. I have 2 large ophthalmology practices that are 2 to 3 ophthalmologists plus their optometrists that are a half mile down the road on either side. I've got a Kaiser, which controls about 25 million lives in the state of California on one side with their eye care facility, and a UC Davis Medical Center behind me on the other side, not including Sight for Shore Eyes and JCPenney Optical and Sears Optical and Stanton Optical, and I'll go down the list. That's the competitive environment that I had the stupidity to plant my practice in. I've found that some of those decisions have been the best at challenging my notions of how to compete and how to be an effective communicator with my patients, how to be an effective communicator and manager of my staff. And I've made 3 what I consider really good decisions as I went through that. 1, I moved to Roseville, California because it was close to my father, who was in business and not in eye care. 25 years in executive management, I learned business from him. And I wanted that tutelage alongside, and he connected me with a series of other mentors, and that made me think about eye care very differently. Second was that as I went along, I wrote into my business plan that trip to India that I talked about, to always make sure I had something that was a guidepost that pushed me to make sure I made decisions that were going to support those notions of service. And the third piece was I hired about 6.5 years ago a manager, and I would take it beyond a manager. This is the COO, Chief Operating Officer of my practice, who has a 6-figure salary in the US, to come in and help me take the business from what it was to where it needed to be. So I surrounded myself with some of these people that did all those things. And those were really critical pieces. But along the way, I made a couple of steps or missteps that created opportunities for me. And one of those was in 2007, I bought a Cirrus 4000 at the height of the market for the bleeding edge price of $79,000 US, because I loved technology and I wanted to get into the technology. And it wasn't the Zeiss rep. He's still a great friend of mine. I really love him to death. And he's still with Zeiss. It was that I really wanted to do this stuff, and I saw the opportunity. And at that point in time, we had a reimbursement of about $120 a scan, on $110 a scan on OCT. So it made complete business sense to go and do that purchase. 10 months later, it got cut to 40, and just chopped the knees out from under me. Not only did it get cut to 40, it got cut to 40 and you couldn't do it on a macula and a nerve on the same day, which really screwed you up when you had built a business model around some of that stuff. So the first thing that I went to, because I was hungry at this point, and I think we already had 2 kids. Maybe the third was on the way. I don't remember in 2007. I forget all those things. So I get there, I get this, I'm sitting there going, what am I going to do with this? How am I going to go about making this work? So we employed what we call in the United States the Optos model. So, well, yeah, I mean, if we get a really good person at the front of house that can sell the heck out of this thing, you know what? I'll get them to convert, and I'll have them pay for this stuff in advance. And then I'll see them on the back side of it because I know that it's really clinically relevant. And if they're really good, we saw 70% conversion. If they were modestly good, we saw 50% conversion. If they were mediocre or worse, it was 20%. But one thing that we noticed consistently, and I had one other doc at this point that had started to fold in to the practice, we noticed that when they sent a patient in the exam room, and the patient said to us, Dr. So-and-so, if you tell me I should have this done, I'm going to go have it done. They did it every single time, no exceptions. And we thought, wow, that's kind of unique. Why is that? What's happening with that? And I think, and the way I characterize it is this, we operate as clinicians in one currency and one currency only. And that currency is the currency of trust. Now, trust is expressed in many different ways for us. Trust can be expressed in how they spend their money. Trust can be expressed in how they spend their time. Trust can be expressed emotionally in a smile. There's lots of ways in which it gets expressed. But the most common ways in our practices is their time and their money, right? And so recognizing that, we said, if somebody's going to trust us, we have to give them a reason to make a decision. What's that decision going to be about whether they trust us and whether they move forward with any other of our care, either recommendations or prescriptions, regardless of whether that's imaging or otherwise. And that was what we stumbled on. So we started to employ a model called baseline exam. And we said, you know what? If we're going to get to any of these and we're going to build a base of patients that we care for with any of these, we want to make sure that we go ahead and we establish that. So we said, you know, we're going to make this across the board. Every single person who walks in will not see a doctor until they acknowledge that they're having a baseline exam. And this was we ran a baseline exam, an OCT, 512, 128, and a 200 by 200 nerve scan. And if they had any questions about it, they could ask the doc in the exam room, but they had to have it done before they walked back. They didn't have to pay for anything, but they had to have it done before they walked back and have that discussion with the docs. The staff were scared. The staff thought, no way, we're going to have them walk out in droves. So the first month, we had 6 patients leave us. They were all 50-plus-year-old white males, and our staff were 25 to 30-year-old females. And 50% of those guys got the kick in the pants from their wives and were back to see us and came back and said, I am here to see you because my wife said to come back in. You have my best interest at heart, right? That, though, was a notion. We had to figure out about, you know, what does that mean around communication? But we also had another thing that we noticed once. We had a kid who came in for an evaluation. We did the whole family. We had 5 people in the family, and we charged them all appropriately as we had set forth. And this little kid was a +5 or a +6 hyperope at the end of the day. Asked about him about 2 weeks later, how'd he do with his glasses? I want to know, first exam, all that sort of stuff. And the staff in optical said didn't get his glasses. We haven't seen him yet. We said, what do you mean he didn't get his glasses? He's a +5, +6. He needs these. These are absolutely critical. And that's the quality of care we've committed to. They said, well, they couldn't get the glasses because they didn't budget for that. But they had budgeted a certain amount, and they spent that on our baseline exam. And so we made an adjustment right there and then. We actually said on families that were booking as a collective together, we did a 50% discount on our fees across every single patient that was part of that family at that point in time. And that's morphed a bit over time. We now charge for those in advance, so that if we've got a family member who wants that discount on services at the beginning of the year, if they want the discount, they have to pay for the full family for the year. So we're collecting those fees up front. It's a very good recall mechanism. We didn't realize that at the beginning, but it's a great recall mechanism. It's a compelling reason. They've already given you the money. They're showing up for that second part of the evaluation. But those are the changes that we made. And we saw tons of things. We'll see 2 to 3 cases of juvenile glaucoma a year. We'll see central serous in a 14-year-old. Because we have a macular image, and we'll turn around and talk to the patient and to the parent. We'll say, what are you doing? Dane, why are you so rough on your kid? What are they experiencing at school that your 7-month-old has central? No, we don't scan 7-month-olds. But what are we doing where we scan these patients and this is going on? And you'll see them a month back, and the kid's in great shape. So there's compelling pieces that we found in our vernacular and the way in which we started this conversation. But here's a side piece that we never expected. We looked at numbers about 18 months after we had instituted this. And 18 months after, we looked back over a 12-month window from the start to the end of it. And we said, what else might have changed in the practice? Is there anything else about us that's been adjusted? We saw an increase in our optical spend of $50 per job. $50 per every transaction that people were purchasing, it went up by $50 on average during that same window. And 4 years after we had implemented it, we saw that number top off at about $100. We had made no other changes in optical in that same window. But what we believe was happening was we put together a very narrow front door. We let patients know what it was that we were about, what it was that we stood for. We left the back door as big and wide open as possible. We didn't care about the back door because if we didn't do our job, they should be free to leave us. But if we did our job, they're not going to want to leave us and they're going to tell more people about us. And why we think that optical spend went up is because we had patients leave us. And we had one stick with us, and they started referring other patients into us for those reasons of our care was paramount, and our optical was an extension of our care. And I can share with you a little bit about what we do in optical and why I think that is. But that became a really big catch for us as we looked at the ripple effects through the clinic. And our clinic now is 4 doctors. We see patients on, we have 4 exam lanes. We have about 4,000 square feet. We also have an IOL master. We do all of our own cataract pre-ops in the clinic. Our surgeons visit us and do the cataract pre-ops in the clinics. We have a conversion rate on our premium IOLs and procedures of 133%. So if each person that got a cataract and had surgery done had a multifocal and a femto, that's 200%. And so we just do that across 200, and we're at 133%. So every one of our patients gets something premium, and then 1 in 3 gets an additional premium treatment from a surgery standpoint. That's what that 133 means. That we came upon through relationship building, and because we have the technology on the back end to build it. Patients were seeking us out for the care and the quality of the care that came along with it. We've seen growth across our behavioral optometry side. So we have one provider that spends time in the behavioral clinic, generating well over what the average optometrist does to justify a salary in a week. She generates in a day and a half.